Good morning, everyone. It's a pleasure to be here to talk about metabolic dysfunction-associated steatotic liver disease in people with HIV, looking for some differences in women. I'm going to follow these points through my talk. MASLD was previously known as fatty liver or non-alcoholic fatty liver disease for more than 20 years. In 2020, an international consensus of experts agreed to change the name. The new term eliminated the stigmatizing words and clarified that this is not an exclusion diagnosis. Only 3 years later, the consensus of experts modified the name, including metabolic dysfunction, which is the main aspect of this condition. Currently, this is the steatotic liver disease definition and classification. Today, I will focus on MASLD, while keeping in mind that metabolic and alcoholic steatotic liver disease shares most of the characteristics with MASLD and is very common in people with HIV who have both conditions very frequently. In this slide, we can see the evolution of MASLD from mild stage to worse stages. At the time of the diagnosis, we need to classify the stage which the subject is in and monitoring the change in the stage regularly. As you can see, the change is possible in both directions. To deal with all this, the main societies have published recently their guideline recommendations for MASLD clinical management. If we focus on the population recommended for screening, we can see similar conditions: type 2 diabetes, obesity, metabolic risk factors, but there are some small differences, like persistently elevated transaminases, family history of liver cirrhosis, or steatosis on imaging techniques. The EAC Society has also given its recommendations with similar populations, adding de-exposure drugs specifically for people with HIV. Summarizing all this population recommended to be screened, who should be screened? In this slide, we can see the main conditions we need to consider. I've highlighted in red those from specific guidelines of people with HIV: metabolic syndrome, overweight instead of obesity, and exposure to D drugs. On this map, we can see the prevalence of NAFLD in people with HIV. It ranges between 30 to 40% all over the world. More recently, in a systematic review with more than 8,000 people, estimate the prevalence of NAFLD. On imaging techniques, 1 out of 3 people had NAFLD, and 1 out of 4 had liver fibrosis. The study highlights the importance of traditional risk factors more than HIV-related factors for this condition. A second simultaneously study showed same figures, but pointing out the role of serum biomarkers, genetics test, and control attenuation parameter for the diagnosis. Unfortunately, in this study, only 15% of the population were women, which limits the applicability of the conclusions. Last year, Sebastiani et al. Explored the metabolic dysfunction-associated steatohepatitis in people with HIV. They studied 373 women with these clinical characteristics. They estimated the prevalence of MASH by FAST score, which is calculated with the measurement of steatosis and fibrosis by transient elastography and the level of AST. They found that the MASH prevalence was lower in women than in men, around 5% versus 9%. They studied the evolution of MASH and observed that women experience an increasing incidence of MASH, coinciding with the transition from perimenopause to menopause, reaching the same prevalence than men by the age of 55 years. With all this data and considering the aging of our course, especially in women, we have a very high proportion of people with HIV to screen, and it consumes a lot of time and resources. In this scenario, it's very important to have clear recommendations about how people with HIV should be screened. As we have seen in the clinical guidelines, the risk of the fibrosis risk assessment is crucial. However, what about hepatic steatosis diagnosis, which is the first step in this condition? Looking at EAC's recommendations again, says ultrasound is the preferred first-line diagnostic procedure. However, it's not a rapidly and easily available resource everywhere. This is why the serum biomarkers play an important and real role. Transit elastography is not an available resource in a lot of centers. In the case you have one, it is really very useful because at the same time you can have steatosis and fibrosis assessment at the same time. In 2022, our group validated the diagnostic performance of serum biomarkers against liver biopsy. We studied triglycerides and glucose index, hepatic steatosis index, and fatty liver index. We found good results with a combination of two indices, which allow us to reduce the use of ultrasound or transient elastography by up to 60% of subjects. Later, we also validated the diagnostic performance of FAST score for MASH and liver fibrosis F1 or more, and we obtained a high area under Rook curve with 0.85. As you can see, the curve obtained in people with HIV was similar than the curve obtained in people without HIV in green. With all these results, in our center, we have implemented an automated assessment of risk of steatosis and liver fibrosis in the routine analysis, which has proven to be highly useful. Our latest research is focused on the role of hepatic steatosis and fibrosis as part of cardiovascular risk assessment in people with HIV. We have studied more than 7,000 naive people from the prospective CORIS cohort, and we assess the hepatic steatosis insulin using triglycerides and glucose index, and the risk of liver fibrosis using 5-4 index. We analyze the association between both conditions and the incidence of major cardiovascular events. We observe an increasing incidence rate of cardiovascular event from healthy subjects to those with one or two conditions. The probability of suffering a cardiovascular event when you have hepatic steatosis, liver fibrosis, or both at the beginning of the follow-up when you are diagnosed with HIV before starting antiretroviral therapy was associated significantly with major incidence of cardiovascular events. In the analysis of factor associated, this condition was an independent factor, and it was also independent of cardiovascular classical risk factors. Once we have the patients diagnosed and stratified, what should we do next? Looking again at the IACS recommendations, we can see two main approaches. One, from a pathological perspective for subjects with risk of advanced liver fibrosis, and the other from a general perspective for subjects with low to medium risk of advanced liver fibrosis. The general perspective is for everyone, as well as lifestyle interventions, weight loss recommendations, or pharmacotherapy for NASH. The reduction of cardiovascular risk is a fundamental goal. As you know, the cardiovascular disease are the main important cause of morbidity and mortality in population with MASLD, with or without HIV infections.
Yeah.
Metabolic dysfunction is another very important topic. As you can see in this slide, we need to take into account the features of metabolic syndrome, as they vary in the degree of dysfunction, and it links with the outcome hepatic and extrahepatic clinical results. And it helps us to identify variable clinical phenotypes. In addition, we have to keep in mind that people with HIV have risk modifiers. Like habits, they have more alcohol, tobacco, and drug consumptions. They have more chronic inflammation. They have higher prevalence of viral hepatitis and the toxicity from antiretroviral therapies in different tissues and organs. In consequence, once the patient, when we have defined the phenotype of every subject, we need to consider this phenotype to choose the pharmacotherapy for the subject. It's very important to look the effects of the drugs in hepatic and extrahepatic conditions. And we must plan a specific goal for every patient when we consider to choose the different drug therapies. GLP-1 agonists are opening new perspective in the treatment of MASLD. And nowadays, they are one of the most important drug therapies. To finish, I would like to review some of the more recent researches in MASLD that I'm sure will change our understanding and approach of this condition in the coming years. From metabolic homeostasis to hepatic inflammatory spillover, there are 5 main organs implicated. Muscle and sarcopenia are being studied in that moment, and we have new concepts like obese sarcopenia or lean MASLD. Another important area of research is the genetic risk. Not only environmental factors or unhealthy diet are important for MASLD, and there are some related genes we need taken into account. Diving deeper in the genetic studies, it's well known that carriers of TNCSF2 and PNPL3 variants have lower risk for cardiovascular disease due to the lower circulating lipoproteins. In this recent study, 2 polygenic risk scores have been described. This phenotype confirms that there are 2 different types of MASLD, one confined in the liver, resulting in a more aggressive liver disease, and other systemic, resulting in a higher risk of cardiometabolic disease. It links with the 2 approaches that we previously have discussed. Looking at sex differences, there are new studies which are analyzing the role of PNPL3 M148M variant with the expression of MASLD, which are, this variant accounts for the largest fraction of inherited fatty liver disease variability. In this study, the authors found an association between women carriers of the M variant and the ALT levels, and this effect was stronger as women get older. Looking at the biopsies, we can see women carriers in yellow. They have more ballooning, more inflammation, more NASH, and more liver fibrosis than men carriers of the M variant. In this study, they added some basic research and observed that individuals with obesity, PNPL3 expression was higher in women than in men. In animal models, it correlated with estrogen levels. In human hepatocytes, PNPL3 was induced by estrogen receptor alpha agonist. With this information, the authors conclude a possible functional interaction between estrogen receptor alpha and PNPL3 M variant, and it contributes to fatty liver disease in women. Another study in women analyzed the microbial translocation and gut damage in women with HIV with MASH, and they observed worse markers in women with HIV for both conditions. Interestingly, they also describe an association between FAST score and microbial translocation and gut damage markers. To finish, in this global perspective of the disease, there are new insights that highlight the need to screen for social determinants of every subject with MASLD. And it is even more important in people with HIV, whose social determinants are worse, especially in aging women. To finish, I hope to have convinced you the importance of MASLD. MASLD is a very prevalent condition in people with HIV, especially important in postmenopausal women. Liver steatosis screening should be done in most people with HIV over 50 years. Serum biomarkers of steatosis and fibrosis should be integrated in routine analysis. An individual risk stratification should be done, including PNPL3 variants when it's available and social determinants of health. And let me finish with a message. The variable severity of metabolic dysfunction and the heterogeneity of liver and extrahepatic outcomes highlight the need for a holistic approach to managing and treating MASLD as a multisystem disease. Thank you for your attention.